Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Immune Reconstitution 2023. This is a list of my sins. I do adjudicate some cases for Merck for a diagnostic test that they are working on. And this is a disclaimer, I think, regarding echo. And perhaps you've all seen this before, but there it is again. In this presentation, I've done my best to keep it patient-centered. This presentation offers a limited perspective of how systemic, social, and economic factors impact health. And we recognize that racism, not race, creates and perpetuates health disparities. So, moving on, immune reconstitution. So this requires a definition, and that is an illness occurring in a person with HIV with a temporal relationship to starting antiretroviral therapy. It's associated with a decline in plasma HIV RNA levels and a rise in CD4 counts. And key is that the presentation must be with an unusual inflammatory course, and you must exclude alternative causes of that illness, like progression of the OI or drug toxicity or a second OI that you were unaware of. Those causes must be excluded. There are two versions of IRIS, paradoxical and unmasking. Paradoxical IRIS is defined when a patient is treated for an already known opportunistic infection and is improving on therapy for that infection, and then deteriorates after starting antiretroviral therapy. Conversely, unmasking IRIS is a disease where the OI or condition was cryptic prior to starting antiretroviral therapy, but then becomes evident after starting treatment and must become evident with florid and inflammatory symptoms, not just the occurrence of typical symptoms of that OI, but especially inflammatory symptoms with that OI. The overall incidence from a lot of studies that are listed down below is about 10 to 13%. Paradoxical IRIS occurs more frequently than unmasking IRIS, and the percentages are listed here. CMV tops the list in most studies with almost 40% of IRIS conditions chalked up to CMV. Crypto and TB and PML around 17 to 20%. KS has a wide range, but overall is less than 10% of cases. And then I just listed a couple of OIs, TB and crypto, and their rates for unmasking IRIS, which are generally much lower than paradoxical IRIS. There are risk factors that are mentioned in many papers for developing IRIS, and they are what you would expect: a low CD4 count and a high HIV RNA level at the start of antiretroviral therapy, a high pathogen burden or antigen burden, as you'd see in disseminated infections. So there's a lot that the immune system would respond to. A strong response to antiretroviral therapy that's marked by a drop in HIV RNA levels and a marked and brisk return of CD4 counts. And then, as it makes perfect sense, there's a short interval between treatment of the OI and starting antiretroviral therapy. So there's still plenty of pathogen around, plenty of antigen around to which the immune system responds. There are some studies that suggest that integrase inhibitor use is associated with OIs more frequently, but only some studies. Others do not support that contention. And then some other risk factors that have been examined in some papers: HLA types, if people are antiretroviral naive, low hemoglobin levels, and PI-based ART. Many of these are just surrogates for the other risk factors that are mentioned above. So the timing, typically IRIS happens in the first month or two after starting up antiretroviral treatment, but there is a wide range, as short as just a few days, which you can see in some mycobacterial related IRIS conditions, and up to 6 months, which has been described in people with CMV IRIS. Median CD4 counts from a large meta-analysis published in 2010 by Mueller are less than 100, typically 57 or so. And mortality, again, from these meta-analyses and other papers listed below, is around 5%, with higher mortality in infections and inflammatory conditions involving the central nervous system. So this is just a long laundry list of clinical symptoms and conditions that have been described with IRIS, and then the pathogens associated with those illnesses. Everything from meningitis, brain lesions, encephalitis, uveitis and retinitis, lots of lymphadenitis, hepatitis, colitis, peritonitis, and pleural effusions, and also autoimmune diseases that are grouped together in some studies as part of an IRIS syndrome. And the list of pathogens that cause these clinical syndromes are listed there with a lot of overlap from one symptom to another. The pathogenesis is well described, if not well understood. It starts with a patient with HIV who has an opportunistic infection and is started on antiretroviral therapy, leading to immune recovery that can be divided into several segments: pro-inflammatory cytokines and recovering CD4 cells that enable effector CD8 cells, and also a return of the innate immune response with better functioning macrophages and NK cells. All of that in the context of defects in regulatory T cells lead to a brisk return of immune function that is dysregulated and exaggerated, leading to these inflammatory syndromes. So that's IRIS as a general phenomenon, and I thought we would talk about a few of the opportunistic infections that are especially written about and occur with IRIS. And for today, I thought we would review TB IRIS and CMV, PML, and then an unusual condition, a CD8 encephalitis. We'll save KS and crypto for another day. So TB IRIS, this is one of two OIs for which there has been an international consensus of the definition of TB IRIS. And that was published back in 2008 and is listed here. So patients must have been diagnosed with TB and then have clinical criteria that are the onset of IRIS within 3 months of starting ART, plus one major criteria or two minor criteria. And the major and minor criteria are listed there: new or enlarging lymph nodes or abscesses, focal worsening of radiologic features, new or worsening CNS, TB, or serositis are the major criteria. The minor I won't go through, but you can see them listed there. And then common to all these definitions is that there has to be no alternative explanation for those symptoms. Unmasking TB IRIS is defined as patients who are not on treatment for TB when antiretroviral therapy is started, but TB is diagnosed within 3 months of starting ART, plus one of the following: a heightened intensity of clinical manifestations, particularly if there's evidence of a marked inflammatory component, or once established on TB treatment, a clinical course that is complicated by a paradoxical reaction. So those are the criteria for paradoxical and unmasking TB that are agreed upon by an international committee. I wanted to bring up the SAPIT study, which is a study that looked at the timing of antiretroviral therapy in relationship to treating people with TB. And the study was designed to start antiretroviral therapy within a month of treating TB, or starting within 4 weeks of completing the intensive phase of TB, so that's usually after 2 months, or starting ART after people have completed the entire treatment of TB. So those are the three groups, and this involved over 600 patients, and TB IRIS developed in 85 of those 600 patients, and you can see this schema at the right. The top line is the patients who were on the early integrated treatment group. The middle is the late, and the lowest is the sequential treatment group. And the y-axis is the probability of developing IRIS. And you can see that the people who were started on antiretroviral therapy early into the course of their TB developed IRIS more frequently and earlier on. These are the symptoms of the people who developed IRIS, mostly respiratory symptoms, pulmonary infiltrates, organomegaly, lymphadenopathy, and so forth. And the clear part of each bar represents the patients who were in the early integrated treatment group. So they more often had these symptoms, but it was the respiratory symptoms that dominated IRIS in this study. Clinical features and outcomes in the patients who were treated with ART early into the course of their TB treatment, the median time to developing IRIS was a little over 2 weeks. The median time to resolution of IRIS was months, and there were two IRIS-related deaths. Compare that to the sequential arm, where it took a month for people to develop IRIS if they started ART after they completed TB therapy. And the median time to resolution was much shorter, and there were no deaths. So starting therapy earlier when there's lots of TB antigen and organism around, then you're more likely to get IRIS early and more likely to have a more prolonged and severe course. I wanted to bring up TB meningitis because I think this paper is misquoted a lot and is worth talking about. This was published by Torek back in, I can't read my writing here, 2011. This is a randomized, double-blind, placebo-controlled trial of 250 patients with TB meningitis. Everybody got RIPE and DEX, and they were started on ART either immediately, so within a week of starting TB therapy, or waiting 2 months for TB therapy. And the key here is that there was no difference in mortality or new AIDS diagnosis between groups. There were more grade 4 adverse events that happened in the group that started antiretroviral therapy right at the time that they started TB therapy. But there was no difference in the neurological events between the groups. And the survival curves are to the right. You can see that there's really no difference between the two. Perhaps we've all heard the teaching of the paradigm that TB meningitis and IRIS is something to be avoided, and you should definitely not start antiretroviral therapy early on in the treatment of TB meningitis. And I'm just not sure that that's true. This one RCT suggests that starting early doesn't really make much of a difference. There are more adverse events, but remember, they were not more adverse neurological events that happened in the early treatment group. This is a randomized, double-blind, placebo-controlled study looking at the role of prednisone in treating people that have TB IRIS. The intervention group got a lot of prednisone, around 100 mg per day for 2 weeks, and then half of that, 50 mg per day for 2 weeks, and were assessed up to 3 months into the study. They could switch to open label prednisone at the physician's discretion if the patient was deteriorating. And the outcome here is in the bottom frame of this table. The primary outcome was total hospital days and outpatient procedures. And you can see in the prednisone group, many fewer hospitalized days and outpatient procedures. And the median numbers of days that people stayed in-house was cut by by 2/3 actually. So that was statistically significant and demonstrated the benefits of prednisone in treating people who had already developed TB IRIS. The conclusions for the study were that prednisone reduced the need for medical interventions. There was consistent benefit of symptoms and radiographic evaluations. There were fewer numbers of patients who crossed over to open label prednisone in this study if they started out on prednisone. And there was no excess steroid toxicity or infections that developed in any of the patients in this study. Optimal duration, this study was 4 weeks, but there were some patients who needed to have their prednisone course extended because they rebounded when prednisones were stopped after 4 weeks. Then what about preventing TB IRIS altogether? This study was published a few years ago now in the New England Journal. The PRED-ART study involved 240 patients who had started on TB treatment within 30 days of starting antiretroviral therapy. They were randomized to prednisone at 40 milligrams per day for 2 weeks and then 20 milligrams per day for 2 weeks. Prednisone decreased IRIS by 30%, and decreased the use of prednisone for IRIS from 28% to 13%. There was one death due to IRIS, and as you would expect, this occurred in the placebo arm. And once again, there were no increased adverse events from taking prednisone. These are just the data presented graphically. On the left is the cumulative incidence of TB at IRIS. This is at 12 weeks, and you can see there was more in the placebo arm than the prednisone arm. And then same thing presented graphically on the right. Okay, so that's TB IRIS. Let's move on to another pathogen, cytomegalovirus and CMV IRIS. So there is no international definition of CMV IRIS. It's not agreed upon as it has been for TB and as it has been for crypto, but that's part 2, which we'll talk about at a later date. So this is not a consensus definition, but from many papers, I think the development of anterior chamber or vitreal inflammation in response to CMV retinitis that occurs after antiretroviral therapy is a reasonable definition. The inflammation can lead to macular edema, epiretinal membrane formation, and retinal neovascularization. On the left-hand picture is just a good shot of a patient with CMV retinitis. You see the yellow exudate and the hemorrhage that occurs, usually following along blood vessels. And on the right is somebody who has vitritis, and you can't even see the retina. The entire vitreous is clouded with inflammation. A meta-analysis of antiretroviral therapy associated IRIS found an overall rate for CMV of almost 40%, so represented the highest, or the OI with the highest incident rate was CMV. Immediate antiretroviral therapy in those with known or suspected CMV leads to the increased severity of IRIS. So that's something worth focusing on when you're diagnosing somebody. If you have someone that you've proven has CMV retinitis, or you're highly suspicious that they have, starting antiretroviral therapy early in those patients, if they develop IRIS, leads to more severe disease. So that's one where you might want to pause before starting antiretroviral therapy in patients who you know or highly suspect have CMV retinitis. Risk factors are the use of intravitreal cidofovir to treat CMV retinitis, which we really no longer do any longer, and then starting antiretroviral therapy before completion of the induction phase of the treatment of CMV retinitis as a risk factor for getting CMV IRIS. Treatment is steroids, and outcome is unfortunately variable, and many patients do not get their sight back. So it doesn't respond as well as other IRIS syndromes. So delay, I think the key here is you should delay ART in those with known or suspected CMV retinitis, and you should obtain dilated fundoscopic exams in all patients whose CD4 counts are less than 100 and who are starting antiretroviral therapy, because if you do find it, then delaying therapy and past the induction phase of CMV retinitis would be a prudent course. Next, PML IRIS. I found this nice paper that's listed here by Fournier in Frontiers in Immunology. They reviewed all reported cases of PML IRIS from 1998 through 2016. And there's a few other series of PML IRIS that are included in this analysis, but many of the cases in these other series were excluded from this paper because they did not meet the definitions of PML IRIS that they established. So this is a pretty tight paper where they chose only those cases of proven PML IRIS and then reviewed them carefully to come up with their conclusions. So their definition was patients had to be infected with HIV. They had to have PML with neurological deficits, a characteristic MR, and JC virus in their CSF or brain biopsy. So they had to have a tight diagnosis of PML. And PML IRIS was defined as having been started on ART in the last 2 years with the subacute onset of neurological symptoms that appeared with ART on masking PML IRIS or worsened in a patient with known PML, so paradoxical IRIS, a decrease in HIV and RNA, a rise in CD4 count, and then key, evidence for inflammation in the brain by MRI showing enhancement, edema, or mass effect, or if the patient had a biopsy done and that biopsy showed T-cell infiltration. So again, a pretty tight diagnosis of PML IRIS to be included among these 46 cases. The timing in these 46 cases was 41 days for unmasking and 38 for paradoxical, so not really much difference. Clinical features were new motor deficits, speech disorders, cognitive decline, ataxia, visual disturbances, seizures. The imaging showed enhancing lesions in the majority, with edema in a third and mass effect in a quarter. Median CD4 counts before these 46 patients started antiretroviral therapy were 45 with a big range. And at onset of PML IRIS, their T cells doubled to 100, again with a very big range going up to 610. JC virus was found in their CSF in 84% of the 38 patients who did get CSF analysis, and histopathology showing T cell infiltration happened in 95% of the 20 patients who went to biopsy. Treatment and outcome. 63% of patients received steroids, and it was all over the map. Some got mega doses of methylprednisolone, others got Dex, others got a combination of those things plus prednisone, so no standard formula. And at 8 months of follow-up, 72% of these patients had improved or stabilized, and 28% had worsened and then died within 2 years. There was no difference in outcome between those who had unmasking or paradoxical IRIS, and there was surprisingly no effect of steroids. 72% versus 71% improved or stabilized, whether or not they got steroids. Now, again, this wasn't prospective or randomized, so maybe there are some differences there that would confound those conclusions. But I did find it surprising that there was no benefit of steroids in this group. And this was, again, a pretty tight group of patients with tight definitions of both PML and PML IRIS. Last condition here that I included as an IRIS condition because maybe that's what it is. This is HIV CD8 associated encephalitis. There was a recent paper published in Neurology that collected 53 cases that had been reported to date. 23 of those cases were scrutinized more carefully than the other 30. Those 23 cases came from the UK. This is severe encephalitis caused by CD8 infiltration of the brain. And clinically, patients present with acute or subacute, so there's the date range, declines in cognitive function and headache more than vomiting, ataxia, cardiac arrest, seizures. So cognitive function decline and headache dominated the clinical picture in these patients. Median T cell count at presentation was pretty good, 327. Of the 16 who had their CSF obtained, 68% were HIV RNA positive. And of those that went to autopsy and pathology, there was perivascular and diffuse CD8 infiltration, but with very little HIV detected in the brain. So lots of T cell infiltration, presumably against HIV, but they didn't find very many HIV proteins or viruses on biopsy, contrasting that with HIV-associated encephalitis, that's responsible for hand, then you can find plenty of HIV in the brain of those patients. This looks more like an immunologic disease than a virologic disease, and that's why I included it as maybe an IRIS condition. Imaging shows multiple bilateral and confluent signal with edema throughout the white matter, more so than the cortical areas. And there's a characteristic MR showing the white matter of part of the brain is lighting up more than the gray matter. Risk factors among these 53 reported cases are having an intercurrent infection. They didn't tell you what intercurrent infection, but having an intercurrent infection, having interrupted heart, having been previously diagnosed with IRIS, And then they just made the observation that 38 of these 53 cases happened in individuals of Black African ancestry. Treatment and mortality, 9 of 30 patients, or 30% treated with steroids, died. 16 of 23 not treated with steroids died. Again, this is not a randomized study, and the steroids used were all over the map, so hard to make any conclusions from that. But if this is an inflammatory condition, then it's possible that steroids might have a role. So, IRIS treatment overall, not just related to all the cases I described here. Continue antiretroviral therapy except in life-threatening situations. Continue treatment of the OI or the condition. For patients with mild symptoms, you can treat them with non-steroidal drugs. For moderate to severe disease, steroids, but not, and I'll talk about this at version 2 of this, not routinely recommended in CNS cryptococcal infections. Although if you read the guidelines, the DHHS guidelines, it says, with a C3 for evidence next to it, some experts would use steroids in certain conditions with crypto IRIS. If you're using steroids, be careful about KS. And if they have concurrent KS, you might consider treating the KS at the same time you give them steroids, because steroids make KS worse. Don't forget to check for or just treat for strongy if you're giving somebody prednisone for their IRIS syndrome. There are alternatives to steroids that are listed there, but it's just case reports for using those agents. So, final conclusions. IRIS is an inflammatory disease that occurs in the context of initiating antiretroviral therapy, and it can be classified as paradoxical or unmasking. The incidence varies greatly by geographic region and disease, depending on, different OIs, depending upon where you live. Major risk factors include advanced HIV, disseminated infections, and a short interval between treatment of that condition and the initiation of antiretroviral therapy. Management generally includes continuing ART, continuing treatment of the OI or condition, and adding anti-inflammatory therapy. Watch out for using steroids for KS and even for crypto. Outcomes are generally good, but there can be significant mortality or morbidity in cryptococcal disease, visceral KS, PML, and HIV-associated CD8 encephalitis. And that's it. You'll get part 2 when Brian and Hillary ask me to do it.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.